Good afternoon. Well, the COVID crisis has had a very significant impact on all of our lives and certainly on the Aging at Altitude webinar and expo series. This year, we were forced to change it to our first ever virtual expo and webinar series. So we're really happy with the participation so far, and I'm sure this will be another terrific presentation. My name is Al Manzi. I'm president and CEO for Prairie Mountain Media and publisher for The Camera and moderator for today's session. Today we'll be hearing from True Community Care, and this is our 11th webinar in the series. It's entitled Hospice and Palliative Care, Knowing the Difference. Before I turn it over to today's speaker, let me remind you of the Q&A and chat boxes at the bottom of your device screen. It's there you can type in your questions during the presentation so that we have them at the end. The presenter today will speak for about 40 minutes, and that'll leave us about 20 minutes for question and answer period. And we've had very vibrant question and answer periods up to this point. Now let's get started. Today we'll be hearing from Jessica O'Leary, patient care consultant from True Community Care. So please welcome Jessica O'Leary.
Good afternoon, everyone. Al, are we okay? Can hear and see? Okay, got it. Okay. Good afternoon, everyone. Thanks for joining me for this topic. I appreciate some of you being very brave because sometimes people avoid discussing hospice and palliative care, but we are all at some point going to reach the end of our lives. This is a support that we may benefit from hearing about earlier more than later. So let's dive in so we can make the use of our time together. Sorry, I'm just looking for there we go. So True Community Care, just a little bit about them before we get into the content, is a local not-for-profit organization. We've been serving the community for over 40 years, and we do these community education presentations as a way to give back to the community and educate and help you all understand your options and advocate for when you're in the situation where you need end-of-life services. So let's start by talking about what is similar about palliative care and hospice. There are definitely some features about both programs that are similar, so I thought we'd get those out of the way before we dive into the differences. So both palliative care and hospice is support for people with serious life-limiting illness. They're collaborative in nature. They are both provided by an interdisciplinary team. We short our acronym internally as IDT, and we look at the entire picture. So we are looking at the physical, the emotional, and their spiritual needs of the patients and their loved ones. We provide the services wherever somebody calls home, and we'll talk about that a little bit more later on. Our goal for both palliative care and hospice is to increase quality of life. Multiple organizations provide both palliative care and hospice. Most of them are for-profit, and then there are not-for-profit options, and they're not all one-size-fits-all. So it's important to know that there's a misconception that people think that there's one organization. There's been many times I've shown up to a coffee shop and had my badge on, and people come up to me and say, "Oh my gosh, you took such great care of my mom, thank you." And then it turns out their mom was in Alabama. And it's wonderful that they're so appreciative, but it's important to know that there are different organizations, and just like anything, to make sure you're doing your research. Palliative programs are usually associated with hospice, and but not necessarily, but some people get scared off of palliative care because they think it's hospice. So that last line on that slide is hospice is palliative care, but palliative care is not hospice. And that's really important to understand because those words are used interchangeably, palliative and hospice, and sometimes people with good intentions use the word palliative care and do not understand that they are fearing it because they're thinking they're being suggested to use hospice when in fact they're just talking about palliative care. I had a patient last week actually who refused to even set up a visit for information because when the hospital case manager entered the room and said, "I want you to meet with a palliative care representative," they flat out refused, thinking they were signing up for hospice. So just keep in mind that those words are used interchangeably very often, but they are absolutely two separate programs. Okay, palliative care. So consultative, that's something that I really want you to hold on to. Palliative care is a consultative program. We do not replace your primary care physician. We do not replace your specialist. We consult with your current medical team and yourself and loved ones. And we are in addition to the team. We're not taking anything away. We are adding on to it. Our job is to help you. We have several jobs, but our job primarily is to help you understand your goals of care versus goals of treatment. And I want to make sure we spell that out, because people really don't understand the difference of goals of care versus goals of treatment. Treatment is, what do we hope to get from this treatment? Of course, we hope to have a cure and to live life as long as possible and to live it well. And that's one aspect, but treatment comes with side effects, and hopefully one of those side effects is getting improvement. But goals of care is, how do you want to spend your time? What does that look like for you? What does that look like for your family? And that could be anything from being able to get up to go to the bathroom independently to being able to go for a hike in the mountains. I mean, there's a huge spectrum there. So keep in mind, goals of care is very unique to you. And our medical system is very focused on treatment and doesn't leave a lot of room for what is it that makes you feel like you're living your best life each day. So that's what goals of care is for, and that's what palliative care focuses on. Advanced directives, you've probably heard, if you're tuning into any of these talks or have come to some of the pre-COVID, offerings, you hear a lot about advanced directives. Well, I'm one more person that's going to tell you, today's the day. Don't put this on your to-do list, just get it done and cross it off. Palliative care is a support that can help you cross that off your to-do list and actually sit down with you and make sure you understand what those options are, because you have sat down to do these advanced directives. Congratulations, well done. If you have not, you might not realize what you're getting into, but these are serious things to think about what you would want in certain situations, and then having conversations with your family, your loved one, or the designated healthcare agent, power of attorney, so that they know how to carry them out if you can't be there to help advocate for yourself. So we can absolutely come out and help you with that. Time. Sometimes the most valuable part of palliative care is the time that we dedicate to our palliative care patients and families. National average, physicians spend about 8 to 12 minutes with their patients in each visit. 8 to 12 minutes. And when you have a serious illness or your loved one has a serious illness, 8 to 12 minutes is certainly not enough. And so a palliative provider, it is not unheard of for them to spend an hour or sometimes 2 hours with you. Even that's amazing. And then you also get the interdisciplinary team, which we'll talk more about. So time is huge. The other aspect is that, in medicine, we stay in our lane. We've got a cardiac diagnosis, the cardiologist stays in their lane. We've got, a dementia diagnosis or a neurology-related diagnosis, the neurologist stays in their lane. Then you've got your primary care that tries to tie it all together. Palliative care is intentionally looking at the entire person, because you are more than just a disease or an illness. You are a person that's lived your life. You've got goals and wishes and bucket list items. You've got things you have done, things you haven't done, trying to make the most of this time. So how does this all tie together? And that's why our focus is on the physical, the emotional, and the spiritual, and not just one illness. How does all of you have multiple illnesses, comorbidities? How do they all tie in together? How do all the medications and the treatments tie in together? What are your options when you're looking at treatment and plans? Are we taking into consideration the entire picture? We are coordinating, navigating resources. That's where our social workers come in. When you have a serious illness, it can be very debilitating, either on a permanent basis or intermittently and temporary. And we have lived in this beautiful state of Colorado. We are so wealthy in resources, but it's pretty daunting to be able to seek out these resources, know what you need, how to navigate, who to call. and to manage it all. It can be a full-time job. And those of you that are caregivers for people who have serious illness, you're doing this every day. So the palliative care team can help you understand what resources are available and point you in the right direction, because my work with caregivers, sometimes they're doing it all on their own for so long that they don't even have the time to ask for help. And any of you that have signed on today that have listened to any of the talks I've given before, you know that I ad nauseum speak about self-care. So asking for help and putting on your own oxygen mask is always number one, okay? So there is help available, but we got to be willing to seek it out and, more importantly, accept it. So palliative care can help with that. Provided alongside curative treatment. So this is the big differentiator with hospice and palliative care. One of the big differentiators that people don't realize, that palliative care is provided alongside curative interventions. So you can continue to seek hospitalizations, you can continue to be seeking treatment, rehabilitation, and still have palliative care support. There are several different models of palliative care: the medical model versus home health model. True community care does provide the medical model. The difference, we're not going to get too much into the weeds about this, but I wanted to make sure you're aware that there's different models, because it's something you don't want to learn after the fact. So a home health model is limited to the Medicare home health benefit, which means that you have to be considered homebound. And the home health model is typically delivered by registered nurses and your home health team, where medical model is provided by providers, so physicians and nurse practitioners, and there are no limitations. You do not have to be homebound. You do not have to have a skilled need, and you can have palliative care for as long as necessary. A home health model, as I mentioned, you're limited to a specific time period, where the medical model, you can have it for as long as needed. So there's continuity and consistency and rapport building, which is really important, again, with serious illness. And hospital versus community-based models. Some of our local hospitals here in Colorado have in-house palliative care teams. Not all of them, but several of them do. I'm not going to list who does. But if you are in a situation where you're in a hospital setting and you feel like you may benefit from palliative care, you can certainly ask, is there a palliative team in-house that you could speak to? And then if appropriate, they can then transition you to a community-based palliative care organization. A lot of times, palliative care community-based organizations have affiliations with hospitals and relationships, so there's a good partnership. But certainly that's something, you can ask for palliative care at any point. You don't have to wait till somebody recommends it to you, okay? All right, moving on. Your expectations for palliative care. This is really important with any service that you bring in, is having appropriate expectations. Because what happens when we have expectations and they're not met? We get disappointed. So again, being educated on what you can and should not expect from palliative care. As I said, there are many different providers. So as you are researching or meeting with palliative care organizations, certainly ask good questions so you know what to expect. And then again, if they are not providing all that you're looking for, asking them to help you find those resources. So who's on the palliative team? And then this is based on a medical model palliative team, okay? So physicians and or nurse practitioners, they're monitoring the physical aspects of what's going on with serious illness. They're the ones that are reaching out to your providers, your primary care physician, your specialist, making recommendations, working with them, having provider-to-provider conversations, which is so important for lines of communication. Any of you dealing with multiple providers, you know that communication is definitely not a strength. So our docs will actually pick up the phone and call. Amazing. And hope to have that conversation and get the sense of what's really going on in your picture. Social workers, as I mentioned, can help with resources. They can also help with counseling. The burden that serious illness plays on the individual and the family is intense. So the social workers can be the counselor to help everybody involved in this, in addition to resources. Chaplains are available. They're non-denominational, and they're spiritual angst and stress along with this. So chaplains are on board to support families and patients with any spiritual conflict they're having. Some palliative teams have nurses, some do not. So I put nurses on there because TRU's palliative team does have nurse on-call support via telemedicine, telecare, but nurses are occasionally part of palliative teams. And then there's, it takes a village. This is teamwork. So there's certainly support staff available. And then some palliative models, TRU's palliative model does have volunteers available, which we are really excited and happy to provide, because volunteers, they're just, I say they're the heart of what we do. And they're not limited to our hospice patients. They are absolutely ready to support our palliative patients as well. So how often do you see your team? That's a common question. And there's no cookie cutter approach. The team visits are based on how you're doing. I do another differentiator is that palliative care is not nearly as robust as hospice. That's why I put that word expect. Palliative patients on average are seen once a month by their provider, sometimes more often, but it can be even less often. It can be once every 6 months, once every couple of months. It's really depending on the level of acuity of the illness. If we're seeing patients that are in and out of hospitals regularly, in and out of rehab facilities, then yeah, and they have serious symptoms that are affecting their day-to-day life, then yes, they are certainly seeing us far more often. But if our patients are more stable, we might be doing more check-in calls and reaching out to them, but we are seeing them on average on a monthly basis. Okay, so that's good to know about the expectation. The palliative team, where do they make visits? Wherever people call home, even if that home is temporary. So home in the community is where most of our palliative patients live. Then we've got folks in assisted living. We've got folks in nursing facilities. We've got folks in rehabilitation facilities. Those of you that are relatively new to this world, just to make sure you're aware, nursing homes have a couple different aliases. So nursing home, long-term care, skilled nursing facility, they're all kind of the same. So just keep that in mind. I put nursing home on there because that seems to be the most common way they're referred to, but that's they're all kind of in the same support services. So wherever patient calls home is where the palliative team is visiting them. Palliative care can be involved for anywhere from 1 to 2 years or longer. Again, a really big difference with hospice. We're taking care of people with serious life-limiting illness, and some of us live with those illnesses for many years. And why not have that support as soon as possible so you can, again, have that increased quality of life and reduction in symptom burden. And most important question, when I meet with patients and families, I try to start off with this, because once I describe services, people get really like, oh my gosh, how much is this gonna cost? So I didn't do that here, but palliative care is paid for by insurance. So we bill as a specialist. So just like if you're seeing any specialist in the community, we bill as a specialist, just a specialist that does house calls. So we bill Medicare, we bill Medicaid, we bill private insurance. So if you or your loved one or somebody at some point is looking for palliative care, or you're seeking palliative care now, if you have a copay seeing a specialist, it's likely you would have the same copay with a medical model palliative care provider. If that was something you were concerned about, the palliative care team would run insurance benefits and let you know of any out-of-pocket expenses in advance. I would say majority of palliative patients do not have a copay, but we are happy to research that so there's no surprises. And as a not-for-profit, TRU does not turn away anybody for the inability to pay. Okay, so that's important to know about what are the differences between for-profit and not-for-profit. When do I add palliative care to my team? That was the title of this presentation. So we got to make sure we designate a slide to this question. Any stage of disease, if you have a diagnosis of a serious illness, then palliative care can be appropriate for you. The sooner we're involved, the more opportunity we have to work with you to maximize the support we can provide. And as I mentioned, the level of acuity determines how often we're involved. So people in earlier stages think, well, I don't need palliative care, and maybe you don't. But if you are pretty stable, then maybe we have you at an acuity where it indicates to us that less frequent visits, but if something changes, you can call us and we can visit more often. And sometimes people don't get palliative care involved until they're, seriously sick and serious symptom burden. And then our acuity, we are seeing you more often. But at diagnosis of at any stage of the disease of life-limiting or serious illness, palliative care can be involved. These are some indicators. The rest of the slide are indicators of when palliative care would be a good idea to consider. One of the questions that I got emailed in advance of this presentation, and I didn't write it down, so I may not get the exact question correctly, but the answer will be speaking to it, was, isn't the goal of all medical treatments to reduce suffering and keep people comfortable? And, in some ways, yes, but in some ways, no. If you think about treatments, sometimes the phrase no pain, no gain comes to mind because the treatment itself can be more difficult to manage than the illness in some ways, but the treatments are focused on getting you better, or focused on treating the disease to maximize quantity of life sometimes. So treatments sometimes have quantity of life in mind and not quality of life. So I hope who put that question in, if they're here today, if that answered your question, great. If not, you can put that into Al and we can address that again at the end. But the goal for us, the palliative care providers, is to maximize quality of life where treatments, that's not always their intention. So somebody that's coming maybe in and out of the hospital because of either the same reason, they're being readmitted multiple times for the same reason. Think of our folks with cardiac disease. Sometimes they are frequent flyers into the hospital, or folks with COPD. And or maybe you're in and out of the hospital because you've got several medical conditions. Well, palliative care is very appropriate for that. One of our goals is to reduce hospitalizations, and I want to highlight in bold that word reduce. We do not prevent, we do not eliminate hospitalizations, but we reduce. A lot of our palliative patients end up in the hospital because of heavy symptom burden. But if we are involved, we don't have a magic wand, but if we are intentionally reaching out to your providers to make recommendations for supporting you to have reduced symptom burden so you avoid the hospital, and again, back to that quality of life. If you're in the hospital, your quality of life is not in a good space. If you're, but any time there's a transition from rehab to home or rehab to a facility, there's a lot going on, and palliative care can be appropriate for that. Need for assistance with advanced directives, we touched on that already. Goals of care that match medical treatments. So this is a big piece. Sometimes we will meet with our patients in anticipation of an upcoming provider visit or specialist visit, so they can understand their disease. A lot of what we do is education. I mentioned we have, our visits can last anywhere from an hour or longer. So we're doing education on what this disease means to them, what this looks like, the symptoms that may arise as a result of the disease, symptoms that may arise as a result of the treatment they're on. So education, and then helping them understand, okay, this is what your goals are. Why don't we come up with a list of questions so that you can go to your doctor and say, this is what you're looking for, and help you understand, help you navigate that doctor's office visit to make the most out of that appointment. And then palliative care, like anything, this is not a sign-in for a life situation. This is not a contract. It's not a gym membership you have to pay into for years and you never use. You can discontinue it at any time and reestablish care at any time. Sometimes our palliative patients, start to do better and not need us anymore, and that's fine. And then we disenroll them, and then we're happy to, if they need us back again, then we step right back into service. So this is not a benefit that expires. You can reach out to us at any time and get support in place. You can even kind of be put on hold and cancel visits and say, I'm doing well, maybe I don't need to see you till next month. there's flexibility. There's no cookie cutter approach. So bizarre to not be able to ask you all questions about palliative care before we move into hospice care. So I'm going to give you take a moment to take a breath. You have questions about palliative care, maybe jot them down on your notebook so that when we get to that 20-minute Q&A at the end, you have those questions fresh, because if you're like me, if you don't write it down, you forget about it because your mind starts wandering to other things. So write down those questions because we're going to dive into hospice. Okay. Hospice, we transition from curative, aggressive, life-prolonging treatment to comfort-focused care. That is the philosophy of hospice, is focusing exclusively on keeping our patients and our families comfortable. And again, that interdisciplinary team approach is involved because we're focusing on the physical, the emotional, and the spiritual support. And that's why you have that whole team, because we're so much more than just an illness. So hospice is support that happens before, during, and after end of life. So people who are they have a terminal illness and they're in the dying, that would be the before. During the actively dying stages, dying has stages. And then after, because after our patients die, we don't disappear. We continue to support the people who love them. We'll talk a little bit more about that in an upcoming slide. Hospice is available 24 hours a day. So I mentioned that hospice is far more robust than palliative care, and that's one of the reasons. Your hospice team is available 24 hours a day, 7 days a week. I tell families all the time, 3 o'clock in the morning, a blizzard on Christmas Day, it does not matter. Your hospice team is there, but it's important to know that we are supplemental. We don't move in with sleeping bags. We're not bringing all of our family and our clothing and everything. No, we are supplemental to the support that you have in place already. Hospice replaces 911. Which is really hard sometimes, because when we've had a serious illness for many years, we're probably in a really good habit of calling 911. We probably are on a first name basis with some of the emergency responders. And they don't even need to look up GPS of how to get to your house because it's Mildred again. We know where we're going. And that's fine. And we need that support. But when it's time to transition to hospice, hospice becomes 911. But we don't respond like 911. So we replace 911 by having a nurse available 24 hours a day to answer questions on the phone, to provide visits. Yep, at 3 o'clock in the morning, that's a hot time. We are very popular at 3 o'clock in the morning. And 7 days a week, because when you're replacing 911, our patients need to know somebody's got their back, and that's what we're doing. The focus is on comfort, not curative. So that life-prolonging, curative-focused treatment stops when hospice comes into play. We are focusing exclusively on comfort. So hospice patients are typically they're not going to the hospital, they're not going to get lab work, they're not going to get x-rays. Their goal is, I want to be at home. I want to spend however much time I have left doing the things I want to do with my family, and I don't want to spend it continuing doing treatment that's not changing the outcome, and it's causing me more harm than good. Not all hospice programs are the same, okay? Again, I told you about that coffee shop visit that I've had many times. In this state, there's about over 80 hospices. In the country, there's over 5,000. Not many people realize that. So there are many different programs, and they're not one size fits all. Expectations. Who's on the hospice team? So the same folks that are on your palliative team, and even some more. So a common misconception with hospice is that when you sign up for hospice, you get rid of your doctor. Absolutely not true. You get to keep your doctor if you want to. You can keep your primary care physician, you can keep your specialist. In fact, we encourage it because they've had the history with you and we're just stepping into the team. So we want their knowledge and their experience with you and their history to help guide us in our stepping into support. So we don't stop their involvement. You have the option to continue to work with them, or you have the option to have the hospice physician be primary and your docs be consultative. So that is a common misconception. You do not have to get rid of your doctor. You can keep your doctor. Most primary care physicians and specialists do not make house calls. Occasionally I hear of some rock star doctor that does, or they have physician house call services involved, which is wonderful. But the hospice physicians and nurse practitioners do make house calls. You get your registered nurse, and the registered nurse with hospice is available all the time. So that's the person, there's a couple people on the team that you're seeing regularly. So the registered nurse, you get a team, and your team is making visits to you based on your need. So you get the registered nurse, you get a social worker, you get the chaplain, and then in addition to that, you get a certified nursing assistant, which for some families is seriously the most important person on the team, because that nursing assistant is the one that's allowing some of our families to go back to being family. They're allowing them to go back to being the daughter, the wife, the brother, and not so much the hands-on caregiver. Although you still very much are the caregiver, the CNA is giving the shower, the personal care, and that's a really big piece. How often do you use your team? Oh, I'm sorry, I skipped ahead. So volunteers. Volunteers are a robust part of our team. This is where one area that I would absolutely encourage you to do research when you're interviewing, if you were to interview hospices. Not all hospices have a robust volunteer program. So Medicare requires hospices, as being a participant in the hospice Medicare benefit, to have volunteers, but does not reimburse for volunteer support. So if volunteers are something that you think you would benefit from, so you would want to really reach out and make sure that that hospice that's going to be so involved in such an important part of your time has that level of support. So volunteers can provide respite. And I will say volunteers right now is changed because of COVID. So again, expectations, but pre-COVID, volunteers were providing respite, pet therapy, massage, hair cutting services, card games. I mean, it's running errands. It's really kind of endless. So COVID has changed that for us right now. We've got a lot of volunteers. I think we have I might be quoting us, maybe over-quoting us, but I think we have between 300 and 400 volunteers, and we've got a lot of volunteers that are sitting very antsy right now and desperate to find ways to support our hospice patients. So volunteers is a big part of this. Grief counselors. As I mentioned, we support our hospice patients after the death of a loved one. And that's really important sometimes for our patients to know that their family is still going to have people looking out on them. And this is what we do. So we have grief counselors that are available to families at no charge for 13 months. And we do that 13 months because we're getting through the first birthday, the first anniversary, the first holidays, the first anniversary of the death. And grief counselors can be refused. Grief counselors can be one-on-one counseling. Grief counselors can be group counseling. So that's a support that's important. That's also a really big differentiator between hospices. So when you are looking at who might support you during a hospice situation, that's something you keep in mind. Do they have a robust, ample grief services team? Am I going to have to drive to Denver to see them if I don't live in Denver? If you live in Denver, of course that wouldn't be a problem. Am I going to have to drive to Fort Collins? Are they available in person? Are they only doing phone calls? Do they have group supports? Things to think about. How often do you see your team? Visit, your needs determine how often, but as I mentioned in the previous slide, our visits are supplemental. So another misconception is that people think hospice moves in, and unfortunately that's not the way the Medicare hospice benefit works. We do not move in. So if our patients are at home in the community, families are stepping up to provide the 24/7 care, and our visits are intermittent, when we're there. Some families have to privately hire caregivers to support them. Some folks cannot provide the care at home, and we have to look at facility placement. As we were mentioning, we're providing care anywhere. Sometimes, we have to change gears. Sometimes we started at home and that's not working anymore. We have to move to a facility. But our visits are supplemental, whatever the primary care is already in place. Where does the hospice team make visits? This is similar to palliative care. The only difference is hospice does not visit patients in rehabilitation. And the reason is that rehab and hospice are paid for out of the same Medicare bucket. So hospice and rehab are not in place at the same time. Some hospitals have contracts with hospices where hospice can be provided in the hospital on certain circumstances. What else does hospice include? Like, if that's not enough, right? Too good to be true. Hospice includes medical equipment. So hospital beds, oxygen, wheelchairs, hospital tables, lifts, bedside commodes. And I mean, really, the sky's the limit as far as medical equipment, as long as it's related to comfort-focused care. And supplies. So depends, wipes, gloves, that's all provided by hospice as well. And hospice provides comfort medications. So any medications related to the terminal diagnosis that are needed for comfort, the hospice team provides, has delivered right to the house. Okay, so that's important. Another big thing. So that last piece, the medical equipment, the supplies, and the comfort medications is another huge differentiator between hospice and palliative care. Just had a family email me over the weekend asking, does the CNA come with palliative care? And not typically. I can't speak for all palliative programs, but not typically, okay? All right, moving to the next slide. A little bit more about hospice. How long can we be involved? So I mentioned that palliative care is for people with serious illness, and the prognosis is usually about 1 to 2 years. With hospice, the prognosis is 6 months or less. Okay, so that means that a physician has determined that based on how this patient is doing, they may not be here in 6 months. Now, nobody has a crystal ball. Nobody knows for sure. I've been doing hospice a long time, and I've seen patients on hospice for minutes. I've seen patients on hospice for years, and everything in between. You need to be eligible for hospice by having a terminal diagnosis that indicates you may not be here in 6 months. At the end of the 6 months, are you still here? Do we kick you off? No. If you are continuing to decline and show that you still benefit and need hospice, then we continue to recertify you. Sometimes hospice patients do improve and they do get discharged from hospice, and then we can enroll them in palliative care. But sometimes they do. Sometimes hospice patients discharge. Sometimes they can discharge or graduate from hospice multiple times. But typically, to be eligible for hospice, 6 months or less. Who pays? Medicare and Medicaid pay for everything I just described at 100%. 100%. So no matter how many times that nurse is there, that social worker, that CNA, whether it's 6 times a week or once, it's 100% paid for. No matter if you need 2 pieces of equipment or 10 pieces of equipment, 100% paid for, okay? Most private insurances have a hospice benefit. So if our patient or family did not have Medicare or Medicaid, then we would look at the private insurance. And again, just like I described with palliative care, we would run benefits. So if there was anything, any out-of-pocket expense, you would know that beforehand. I'm not going to get too much in the weeds on the next one. Does hospice have levels of care? But I will mention that there are 4 different levels of care. And I will say that routine is where most hospice patients are. They're home, they're stable. Respite is a huge benefit for hospice that, again, people just don't realize exists. So respite is a hospice benefit that means hospice will pay for 5 days of 100% covered care, either in a hospice inpatient unit or in a skilled nursing facility for caregiver breakdown. So that is a huge benefit. For those of you that are caregivers, we always need support, and the hospice piece does provide 5 days of paid caregiving, okay? And that can be used more than one time, of course. General inpatient is a support because as we replace 911, sometimes our patients with serious illness get into a symptom management crisis, meaning unmanaged pain, unmanaged agitation, uncontrolled nausea, vomiting, whatever it may be. We need to make sure we have a good support system so we don't end up exactly where we don't want to be in the emergency room. So general inpatient level of hospice is we have to get this patient aggressively managed with comfort measures. So we will do that in two different ways. One, True has an inpatient care center. We will take our patients, if that's okay, we don't just go there and pick them up and move them over. We have conversations, of course. We will take them to our inpatient care center and provide 24/7 care to get their symptoms managed. We have nurses there, we have social workers, we have chaplains, our docs are there, and we get their symptoms managed. And then we get them stable, and then they can move back home again. And sometimes patients do end up dying at the care center. General inpatient hospice can also be offered at a skilled nursing facility. So if a patient was at a nursing facility already and had managed symptoms that were not managed, we don't have to uproot them. That's hard on everybody. So we could keep them at the nursing facility and support them there. And continuous care is also for symptoms that are not managed and patients are at home or in an assisted living. And we have our team at the bedside for an extended period of time until we can get those symptoms managed, okay? So hospice is a place. Again, common misconception, you hear that a lot. Well, if I go in hospice, that means I gotta go somewhere. No, not necessarily. Most of our patients are at home in the community. It can be a place. I mentioned that we have an inpatient care center. Yes, we do. True has an inpatient care center. It has, some hospices do, most do not have inpatient care centers. So that's something if you were thinking you might need an inpatient hospice stay or want that as a security blanket, that's important to know. Does your hospice have a plan in the event that you do need that? So, but it can be a place, but most patients are in their own homes. Specialized programs, a differentiator with different hospices. Sometimes there's disease-specific programs. There's cardiac, there's dementia programs. Veterans have very specific end-of-life needs, so that's important to keep in mind because there are a lot of veterans have post-traumatic stress, and that really comes up during end of life. So are there specific training on board with your hospice team to be able to manage any needs of veterans? 11th Hour is a beautiful, beautiful program that True is very, very proud of. And that's a program that's volunteer-driven for patients who are actively dying and do not have somebody to vigil or sit with them. So we have volunteers that will go and sit with our patients who are actively dying. Actively dying is something that we consider as hospice providers to be in the last few days of life. Same thing with the end-of-life program. So end-of-life program, we have a specific team set up to support families who are in the last few days of life with their loved ones. And then I mentioned about grief support already. Just finishing up here and we'll get to the questions. When do I add hospice to my team? Diagnosis of terminal illness. So the last 6 months, that's the diagnosis of terminal illness. Treatment options have been exhausted and/or, that and/or is important, the goal of care has transitioned from curative to comfort. So you don't have to, patients do not have to wait until the doctor says it's time for hospice. You can have a terminal illness and pursuing curative interventions and get to the point where you say, I'm done with this. I'm done. I want to be comfortable. You can then say, I'm ready for hospice, or I want to talk to a palliative and hospice team. And sometimes the doctor comes in and says, we've exhausted curative interventions, and now the time is to switch to comfort focus. When the burden of treatment outweighs the benefit, sometimes people will still stick with treatment, and that's perfectly fine. That's an individual choice. But sometimes people say this treatment is just not working. Goals of care in alignment with hospice. We don't want to bring you into our program unless we're all on the same page, because we're going to be a barrier to treatment if that's ultimately what you want. Hospice benefit is 6 months. Unfortunately, the majority of patients are only with us for about 7 to 14 days, which is really, really sad. And anyone can initiate calling us or calling an organization and saying, I would like to sit down and ask questions and do an informational visit. And we are more than happy to do that, okay? You don't have to wait for a physician order, but a physician order is required to be enrolled in either palliative care or hospice, but we can do informational visits at any point. Some resources for you. So National Hospice and Palliative Care Organization is a great resource. And then a couple of years ago, Medicare put together a hospice compare. So you can actually go online and compare a couple hospices at a time. And they get this information because once people die on hospice, Medicare sends family surveys and asks, how did this hospice do taking care of your loved one? That's not a great time to fill out a survey. Certainly don't want to be going through that, but we take that feedback very seriously because it helps guide us to make sure we're doing what we intend to do in our mission. Okay? Thank you all. All right, time for questions.
That was outstanding, Jessica. You know, you said when we were talking initially that you really build your presentation around questions, and that's exactly what you did. So I'm glad that you built it that way because it was so effective at answering a lot of questions. Like I said, normally we have 10, 15 questions in the queue, but because of the way you built this, I don't think we'll get as many questions. So let's see what we have right now. How do you qualify for palliative care? Who authorizes for insurance purposes?
Great question. So to qualify for palliative care, a serious illness is what you need. And then, you know, insurance, so a physician order is written, and then, you know, the physician sends that to the palliative organization that's chosen. And then for True, we set up an initial consultation and we bill insurance as a specialist. So a serious illness is really all you need to qualify. It's not as strict as the hospice qualifications, excuse me.
Thank you. Can you tell us the geographic area that True Community Care covers?
Yes, and it is expanding all the time. So historically, True has served Boulder County and some of the outlying counties, but now we're going from Berthoud all the way into Denver. We serve the mountain communities, and we're going out east. I don't want to say exactly how far east we're going, but typically about 30 miles from our Lafayette office in any direction is where we're going.
So let's talk a little bit about comfort medications. The first one is, how does one use morphine and Ativan to best affect and also enable the patient to be conscious with the family? I ask this knowing morphine is often an assist to dying.
I see that my friend Ruth asked that question. Thank you, Ruth. That's a great question. I should have included in the presentation because morphine is, comfort medications also a lot of times with our families are feared. So morphine, we have a list of common comfort medications we use. Morphine is one of them, Ativan is one of them, Haldol. We use medications to help with symptoms, for pain, for breathing. Morphine is a medication that's commonly feared because of how it was utilized years and years ago. So we have to do a lot of education with morphine. But all of our medications, we start with a very small dose and we work our way to see how effective it was. And we don't increase the dose unless it's warranted. And we're doing education all the time. When we're looking at hospice end-of-life situations, sometimes patients either come into hospice or get to the point where swallowing is difficult. So our medications come in liquid form because we certainly, when we're there to specialize in comfort, we don't want to cause choking. So we will teach families how to administer liquid medications to help control the symptoms that are causing discomfort.
And along those lines, is anybody, are you using any of the medical marijuana, edibles and lollipops and things like that for nausea and appetite?
So yes, palliative and hospice patients are certainly utilizing CBD and THC in those. As a hospice provider who's Medicare funded, we cannot prescribe those, but we certainly want to be aware if they're using them. Sometimes we will even recommend them. we want to know about it, because if any medications that you're currently on or that we're going to be prescribing, we want to make sure there's no adverse effects. So any at all medications we'd want to be aware of. And yes, some of our palliative and hospice patients have had great relief with those medications, and we support their use of them.
Thank you. On average, how much does it cost a year for palliative care?
I guess I need to respond to that question with a question. Do they mean per person or as an organization?
Yeah, I mean, it's also I would think it would depend on what care you're giving, right?
Yeah. That would
What is the malady?
Right. And as I mentioned, if they're asking that question based on the individual, as I said, most patients palliative care is covered by insurance. If there is an out-of-pocket expense, you could look at, it's usually because there's a commercial insurance involved, and you could look at the insurance card and see if there's a specialist listed and whatever the copay is with that. Per person cancer, they said. Is that right?
Yes.
I guess it honestly, palliative care is covered under insurance. A lot of times, so if you're looking at, so Medicare pays for palliative care 80%, Medicaid covers palliative care 100%. Individuals with Medicare that also have a supplemental insurance, that's where sometimes the supplemental insurance will pick up the copay, sometimes they won't. I've seen copays anywhere from $10, $60 is the most, but it's pretty rare. It's pretty rare. And if you've had deductibles, a lot of times you've met your deductible and then it wipes out the copays. But we would run those benefits before.
So Jessica, you had mentioned something that surprised me, that most of your hospice care is being completed in 7 to 14 days. Is that because the comfort medications are so effective at comfortably ending life, or is there some other reason for that?
No, it's because people wait until they're in their last week or two of life before they enroll in hospice. So they're dying, their disease has progressed to the point that they're in their last weeks of life. And then for whatever reason, there's been a barrier to get hospice involved sooner. And there's multiple factors there. One of them is there's denial. There's fear of the H word. I can't tell you how many times I've met with people and they ask you what you do for work and you say hospice and they back away. Like if they talk to you, you're automatically going to die. And it's denial, it's fear of the word hospice, not spending time listening to a presentation like this to understand how robust and supportive hospice is. And it's that our healthcare and medical system is designed to treat and to cure. And our physicians take this beautiful oath to do everything they can, and our system is, we can keep people alive for a long time, which is beautiful. But if you get to the point where it's more of a burden than a benefit, you can ask for hospice. So most of our patients, and this is a national average, is not unique to True, is that they wait too long. And we hear the feedback in those surveys we get, I wish I would have called you sooner, because they see how supportive we were. But yes, comfort medications do an amazing job, but nothing hospice does speeds up the dying process. We support the person and meet them where they're at and allow them to have a natural death with dignity and keep them comfortable.
Yeah, that was my next question, is that a national average? So is our area more likely to delay the request for hospice or join, taking part in it, or was it a national average? And you had said that's a national average. So it's that same issue across the country, not just here.
Not just here. No. And it's just, it's a lot of fear. It's a lot of fear and denial, not realizing that when we can step in. So palliative care is helping because we're allowing people to be comfortable, as comfortable as possible, but no, national.
And what's your average on palliative care?
That's a great question. I don't know the answer to the top of my head. I would say, I think sometimes people perceive palliative care as a bridge to hospice. So certainly it could be months. but it can be years. So I think it's probably, I'd say it's probably anywhere, it's probably, my guess is probably about 9 to 10 months, but it could be far greater than that. I'll have to find out. It's not me.
And what are the most common illnesses or maladies that you're working with palliative care on?
We have a lot of oncology patients. They have heavy symptom burden from the disease itself or the treatments. Cardiac, COPD, dementia. True is gearing up to put out a specific palliative program for dementia patients and families, because it's, our dementia caregivers need a whole lot. Kidney, nephrology. There's really any illness, but a lot of cancer, cardiac, and COPD.
Excellent. Well, wait, we do have one more question. Hang on. In palliative care team, is the MD your primary care MD or from True Community Care?
In palliative care.
Palliative care, do you have your own physicians for palliative care, or are they being treated by their own physician?
So with palliative care, we are consultative. So your primary care physician and specialist would be primary on palliative care. The true MDs are considered consultative. One of the benefits of palliative care is if we are looking at a situation where we're anticipating that hospice will be a need, you're establishing a relationship with that physician on palliative care, who then stays actively involved when the transition to hospice happens, which is really nice for continuity.
It's outstanding. And most people have had experience, if you've lived around here for any number of years, with True Community Care. And I can tell you that your reputation is outstanding, your work is outstanding, your team is incredible, and you do amazing, amazing work for this community. And I know I speak for everybody that's listening today and have been impacted by your level of care and your concern for the families, and we thank you for that.
Thank you, Al. Thank you for aging it out to the Daily Camera, for putting on such a fabulous event and being flexible to make this happen during COVID.
And we actually had somebody who said, most honest and informative lecture class I've seen on hospice. Thank you for I agree with that. And thank you for your upfront, honest information. Yes, and to clarify, there is an MD in True Community Care for palliative. I think that there is a little bit of confusion there. Primary care physician still is your primary care provider in palliative. There's True Community Care's work is consultative only, correct?
Yes, so palliative care, our doctors as specialists. So depending on what disease is, you have specialists. We are specialists. And True has 3 full-time physicians and 3 full-time nurse practitioners on staff.
Really an incredibly informative presentation today, Jessica. We thank you so much. I want to remind everybody today that they can go to dailycamera.com/aging to visit our virtual expo, so you can help support our partners in this program. Tomorrow's presentation is on telehealth. We all know how much more. If you haven't had a telehealth session with your doctor yet, I'm surprised. It's becoming more and more and more popular, and probably after this COVID situation, we're likely to see that continue, and we'll hear about that tomorrow. So I thank everyone again for attending today's session, and I wish you a great afternoon. Thank you so much.